Hello everyone. Today we are doing a quick revision on androgen insensitivity syndrome, also called as testicular feminization syndrome. Here you have to remember that the person is resistant to androgens, testosterone and dihydrotestosterone. There might be two types, that is complete androgen insensitivity syndrome and partial androgen insensitivity syndrome. Let's begin with complete androgen insensitivity syndrome. Here it is an X-linked recessive disorder. So there is a mutation in androgen receptor which makes it completely resistant to, the males are completely resistant to androgens, testosterone and dihydrotestosterone. So the person is XY chromosome, whereas SRY gene is normal, the testes are normal, so there will be normal Sertoli cells and normal Leydig cells. Now these Sertoli cells will release normal anti-Mullerian hormone that will regress Mullerian duct, and there will be no internal genital female internal genital organs. Whereas there's also release of inhibin B, which gives negative feedback on FSH, so FSH is also normal. And then there's Leydig cells, that is normal, so it releases testosterone normally, whereas this normally released testosterone is not put into use as there's no receptor that is accepting the testosterone. Okay, so what are the things that are normal and what are the things that are abnormal? Normal 46XY person having normal SRY gene, normal testes, normal Sertoli cells and normal Leydig cells. FSH is normal, so no female internal organs. Testosterone level is normal, but resistance is present. So what is this resistance leading to? This resistance leads to Wolffian duct that does not grow, so there is no internal male organ also. Female organs also absent, male internal organs also absent. So there is failure of scrotal descent. So testis is present, but those are abdominal testes, remember, and these should be taken care of or else they might lead to malignancy. Then we have testosterone, which converts into dihydrotestosterone. This dihydrotestosterone is resistant, so there is failure of masculinization of external genitalia, hence this person has female external genitalia. Remember, no internal female organs, no internal male organs of genitalia, whereas female external genitalia is there because that person is resistant to dihydrotestosterone. Hence, in puberty, what are the changes we see is that testis is converted to testosterone, which is resistant. So female, there is no secondary sexual character development. Then there is no pubic hair or axillary hair development. But remember, testosterone is converted into estrogen by aromatase that leads to breast development. So breast is Tanner stage 4 or 5 development is present. So there is, like, you get a female who's at puberty has facing a primary amenorrhea, whose breast development is Tanner stage 4 or 5, but pubic hair and axillary hair development is Tanner 1 or 2. Female looking external genitalia is there, so that person might have AIS, androgen insensitivity syndrome. Okay, now what is the hormonal profile? Hormonal profile will be as such that there is testosterone generally gives negative feedback on GnRH, but since there is resistance of testosterone, there is no negative feedback, so GnRH will release FSH and LH, but inhibin B will inhibit the FSH, so FSH is normal, whereas LH should be increased. So the hormonal profile is increase in LH, FSH normal. Testosterone, when you compare it to a female, it will be increased. Okay, now how do you manage this patient? We have to continue her treating as female, so continuity of identity of female should be done. So what we'll do first is the testis, that is abdominal testis, should be removed, gonadectomy should be done, and this should be done when complete breast development is done, so by age of 16 or 17 years old. Now estrogen replacement therapy should be given, progesterone is not needed because uterus is absent, vaginoplasty should be done, and this can be done just before or after marriage. Here techniques are Mac lunge vaginoplasty or Vischer technique of laparoscopic vaginoplasty. Then we have partial AIS. Here the person is partially sensitive to androgens. So what happens is that female at birth, but there's no female internal organs. Male internal organs will be present, which are partially developed because of presence of partial testosterone sensitivity. So poorly formed of male internal genital organs, and then the testosterone which converts to DHT gives rise to ambiguous genitalia. Okay, now females at birth, we know. What are the features? Primary amenorrhea due to absent uterus, as we know. breast tinier stage 4 or 5 but scanty pubic hair and axillary hair. Clitoromegaly will be present, or labiosacral fusion will be present because of ambiguous genitalia. Okay, so this is one of the most common cause of ambiguous genitalia in 46XY chromosome person, and most common cause of male pseudo hermaphrodite. Okay, how do we treat? Treatment is same as complete AIS, but what should be remembered is that the gonadectomy should be done as soon as possible, because we don't want the person to get an ambiguous genitalia, and virilization should not be happening at the time of puberty. Okay, that's it. Bye bye.